Welcome everyone to the Skilled Nursing Facility Consolidated Billing, Just the Basics. Now this is a starting course. We do offer a variety of other courses throughout the year to help fill in the gaps. The reason that we call this the starting course is it's really high level information. It's not in depth on any given topic related to skilled nursing facility, consolidated billing. Please keep in mind when we talk about skilled nursing facility consolidated billing, this is different than how a SNF bills Medicare, how a skilled nursing facility bills Medicare for a claim for payment. They are two different things, and we'll explain that in just a little while. My name is Tom Ryan. I'm with Provider Outreach and Education. I'll be your presenter. Today, you will also hear Mary Muko. She's one of my teammates and a friend. She gets to help with the chat, the technical issues, anything like that that's going on. So please keep that in mind. Couple of little things I want to go over before we get too far into this. First, if you are interested, you can download the presentation. It is the PowerPoint, and it's the training center that you would go to for that. I did have one question, and so I just want to take a second as part of this to show that person who's obviously new, and I don't want them to not have this available. So let me just show you what I'm talking about here. Our website is wpsgha.com. Again, I'm on our website. You can see it has the WPS logo and the snowflake here. On the top, move to the word Training Center. It's in the middle. When you open the Training Center, you'll go to Live Events. On the Live Events page, there's a chart. The chart will be set up, and to get the material, you'll download it. This is where you will get the PowerPoint from. So that's the first kind of training thing. Again, I do want to make sure that that person who asked me that question does have it available to them. Once we remove it from the live events page, we will post this recording onto the Encore presentation page. It will remain there for 60 to 90 days, but the Encore presentation will be available on our YouTube channel until next year when we redo this course, or until we redo this course again, until the information changes, whatever causes us to take it down. We only do that though if something changes or we actually redo the course live. I'm going to encourage you to use the chat for questions. I will stop at various points to make sure you have what you need. After this event, CMS does like us to ask you to take the survey. The survey does help us gauge the event, how WPS is doing, and all of those different pieces of information. So please take that survey when we get to that point. A couple of pieces of reminders here. The material is just a tool to assist the provider community. The Medicare rules do change often, and they are always going to be above this material. This material is just here to help you. I did try to make sure the material was as accurate as I could this morning. As far as I can tell, it's good to go. There were many questions asked, and I will give you the information that I have based on the facts given in the questions. One of the things that happens within consolidated billing is when we look at the procedure code and when we look at some of those types of things, it actually can affect the answer. If you didn't give me a procedure code and you ask me a generic question, I may not be able to give you a full and complete answer. Please make sure that you do access the CMS website for current information, regulations, and rulings. I will tell you in this course, the CMS website is a big part of consolidated billing in that it does contain the files that you're required to follow. So we'll talk more about that CMS website and the importance of it as we get into the course. So what are we here to do? Well, we're going to start with providing the building blocks to understanding skilled nursing facility, SNF consolidated billing. This is, again, not how a SNF bills Medicare. Instead, it's how the SNF works with outside providers that they are required to work with. That's what consolidated billing is. We'll talk more about that as we give you a definition. We will give you some background information, and then I will show you some resources. Now, I will tell you that at various points in time, the question that you asked may lead me to show you a resource even before we really get going into too far into the answer. So we may get resources out of order. Okay. So let's start with the first section. And the first section really is the building blocks. It's what are the definitions that you need to know? Because without those definitions, you're not going to be able to get the really basic information. I will tell you that we had 3 or 4 people who, when they registered, said, I'm new to Medicare. I'm a new office manager. I don't understand this concept. Can you start at the beginning? Well, in order to meet those needs, I do have to start with the definitions. I do have to provide really high level information. So that's where we're going to start. I will again tell you there are other courses that go with this. And as we get through those, I'll highlight some of those different pieces of information. Okay. So let's start with the basics. Really the basics. Skilled Nursing Facility Consolidated Billing, or SNF CB. What is it? It is a form of bundling used to assign payment to the skilled nursing facility. So it's something that makes one payment for all included services. If you notice, it says during a Part A covered inpatient stay. What is Part A? It is Medicare's inpatient care coverage. It's literally what it is. It's facility coverage for the inpatient care. It is not all of the professionals. So a doctor goes in to see someone in a facility. That's a professional service. That's a Part B service because it's a professional service. Part A is only inpatient. It's only facility. Okay. Now, Part A has limited benefits. That means they cover for a certain number of days. And once we get outside those days, then it's no longer covering certain things. We'll get into that in just 2 slides because we did have some questions on that. So I want you to hold for 2 slides. When we look at this bundle, CMS has determined that there are certain services that are outside the skilled nursing facility's scope of practice. In other words, they can't possibly be responsible for it because they don't even provide these services normally. It's not something they can do. And so because of that, they allow Medicare to be billed directly for that. So that is what consolidated billing is. It is a bundle in which a provider outside of the SNF must determine if they should bill the SNF or should they bill Medicare for their service. The SNF in turn must determine whether or not they are responsible for paying that outside provider, or are they responsible for billing Medicare, meaning return it back to that provider and have that provider bill Medicare. If the SNF is responsible, it can be part of their prospective payment system or their bundled payment, their one per diem based payment. I'm not going to get into a lot of the SNF payments and things like that. We really are going to look at whether or not an outside entity should bill the SNF or Medicare, because that's what consolidated billing really talks about. It's that bundled process, that part where you have to determine that. So the first thing that we have to establish is skilled care. In order to be part of consolidated billing, the patient must be in skilled care. They cannot live in the nursing home. It can't just be part of their daily life. They also have to meet what the Medicare definition of skilled care is. If they do not, yes, they could be in a skilled nursing facility, but Medicare will not be paying. Therefore, the bundling concept called skilled nursing facility consolidated billing does not apply. So skilled care is considered nursing and therapy care. It has to be safely and effectively performed by professionals or technical personnel. Now, these are state licensed professionals or technical personnel. The state sets the criteria. Okay. They can be under the physician of a supervision. In most cases, they will be. There will be someone who is, at a minimum, the skilled nursing facilities director, medical director of service, however you want to term them. We've heard a variety of different terms, but they are usually a physician. Okay. So when Medicare uses the patient's medical need for nursing and therapy of care, it means that you must be to treat, manage, or observe the patient's condition to either improve or stop deterioration for a period of time. Okay. So treat, manage, and observe the patient's condition. It also means someone's got to evaluate that patient's condition. We do require those evaluations. Are they improving? Is this still medically necessary for them? Is there a potential for improvement? Are we trying to keep them at a certain level without a decrease? What's going on? That's all part of the skilled care. If that is not needed, the patient may remain in that skilled nursing facility, but we will not follow the skilled nursing facility consolidated billing or the bundled rules. Which means that Medicare does look at 2 types of skilled nursing facility stays. The first one is the Part A stay. Now, this is one where Medicare is covering the inpatient care. When we look at this, inpatient care or Part A stay, it is for 100 days during a benefit period. I haven't defined for you what a benefit period is yet. We will get to that in just a moment. We also then divide that further, and you have 20 free days and 80 copay days. That matters to the people other than the SNF. Here's what else you have to know though. There is something called a Part B stay. This is when they remain in a medically necessary stay. However, the 100 days is used, or they didn't meet a technical requirement for the stay to be covered. So that would be the 3-day qualifying stay as an example. And that means that they're in the hospital, a hospital of some sort, for 3 days before entering the skilled nursing facility. That 3 days must occur within 30 days of entering the skilled nursing facility, unless planned and documented as planned outside of the 30-day time frame. So here's what you have to know about the 3-day. It does count the day of admission. It counts 2 full inpatient days, but it does not count the day of discharge. So someone said, well, so really it's 4 calendar days. And the answer is correct. It is 4 calendar days or 3 midnight census where they're inpatient in that hospital. So we said it's 100 days in a benefit period. A benefit period is simply the time in which Medicare either pays a benefit or doesn't pay a benefit before there's a 60-day lapse in inpatient care. So it can be Part A and Part B stays in one. There are people who will have one benefit period in a lifetime, such as a tube feeder, who never leaves the skilled level of care. Or there are people who may have multiple benefit periods in a single year because they do lapse with a 60-day time frame within that 365-day period. So remember, it's kind of different depending on what's going on there. A benefit period is not benefit days. A benefit period is the total package, both benefit days and non-benefit days. Benefit days are something when Medicare Part A is paying, it's that Part A stay. Non-benefit days, when Medicare Part A is not paying, that's that Part B stay. Okay. The term Part B stay comes from the fact that yes, if a patient has Medicare Part B, you can still bill Medicare for certain things. Even the skilled nursing facility can. There are still certain things that are billable. So hopefully all of that makes sense. I will tell you, if you didn't get all of that explanation, by all means, feel free to put some more information back into the chat, and I'll go a little bit further into it. Let's keep working a little bit back and forth with some of these different terms. The first thing I want you to be aware of is excluded services, because there are 2 types of excluded services when you talk about skilled nursing facility, consolidated billing, bundling. The first type is literally Medicare excluded services. Medicare is never going to pay for that. That could be from 1861 in the Social Security Act, and it's just literally not covered. These services, if they are excluded, will always be the patient's responsibility. Even if they're in a skilled nursing facility, it doesn't matter, because you can't bill Medicare and the skilled nursing facility can't bill Medicare because the law said no. There is also a type of excluded services that is the SNF Consolidated Billing, the bundling exclusions. Now, these ones are not necessarily excluded from the Medicare payment. As a matter of fact, what we're saying is, as an excluded SNF CB service, you, the provider performing it, will bill Medicare for it. Don't bill the SNF. And that's where we have to have lists on the CMS websites to define those, okay? So hopefully that makes sense in the 2 types of excluded services and who's responsible. Again, Medicare excluded services, always the patient responsibility, because it's not covered under the law and nobody can bill Medicare for it and get a payment. Doesn't mean you can't bill Medicare and get a denial and bill that to a secondary insurance or something else. That's okay, you can do that. However, the SNF Consolidated Billing excluded services simply means it's not part of what you would bill to the SNF. You would bill it directly to Medicare as an outside provider. So let's go ahead and move forward from excluded services. One of the questions I got specifically was on the 3-day qualifying stay, and how do you determine if the 3-day qualifying stay has occurred? First, many times it's the skilled nursing facility who's going to determine this. Second, if you as an external provider are looking at it, things you're looking for, was the patient in observation care? Because remember, the day of admission to the inpatient care is day 1. Observation is not inpatient. Observation is considered outpatient by Medicare. Therefore, were they in observation care? Okay, so once they were admitted, and again, we're not looking at necessarily just an acute care hospital. It could be a critical access hospital. It could be any type of intensive care, or I'm sorry, long-term care. I don't know where intensive care came from. Long-term care hospitals would qualify. Inpatient rehab facilities, inpatient psych facilities, these all have those types of qualifying stays, okay? But admission is day 1, then you'll have 2 full days, and then you'll have a discharge day, which does not count. So the 3-day qualifying stay must occur. There's a couple of caveats, and again, I talked about this, but I really needed you guys to remember this one. The 3-day qualifying stay must occur within 30 days of admission. This is not business days. This is calendar days. Now there is an exception, and it just says, hey, if there's a written plan for longer time frames, as long as it's written out, we understand that. Okay. Hopefully that makes sense for the 3 qualifying stays, because remember, if they don't have a 3-day qualifying stay, then it's not going to count. And of course, there's an exception when there's a Medicare Advantage plan, which doesn't require the 3-day qualifying stay, and then they switch back to regular traditional fee-for-service Medicare. There is an exception, but that has to be billed, and that's going to be part of the billing course that would happen. We'll talk more about that in just a little while. All right. Oops. So we had a lot of questions come in. I've addressed a couple of them. At this point, if you do have a question, best thing you can do is put it in chat. Let me just address a couple more questions that actually came in, and we want to make sure that they're ready to go. So, does a consolidated billing affect every provider type? We're going to talk about that next, but really, no. And yes. Wait a minute, what? Remember, a true professional service that's billed by a physician or billed by a professional is not affected, with the exception of PT, OT, and SLP, because that's part of what they're there for. So physical therapy, occupational therapy, and speech language pathology. When we say no, or when we say yes, we're saying, okay, but what if they go to a physician's office and they're seen by a physician, but the physician does this type of a service and it's not necessarily considered a professional service, or it's like a lab test where they would have both? That could be affected because there's a technical component and a professional component. So it's very complex, and that's what we're going to look at next. The next question that I just wanted to address here to remind everyone again, when we talk about consolidated billing, does it mean that the SNF gets more money? And the answer is no. That's part of their prospective payment. It does mean that you need to bill the SNF, and the SNF is responsible for paying for you. That's part of their conditions of payment. This is from a federal law, and we'll talk more about that in just a few moments. With that, Mary, do we have any questions on those definitions or anything else?
We do not.
Okay, let's go ahead and move on. And we're going to talk about the background information. This is really the high-level overview that people were looking for. I needed to start with giving you guys some basic definitions to kind of get you into a starting point, so when we hit these goals, when we hit this information, we're not kind of stuck out there and not understanding or trying to define everything. So first, what is the goal of SNF Consolidated Billing, Skilled Nursing Facility CB? So my favorite comments on this one from a provider is the goal was to annoy providers. Probably not. Okay, the ultimate goal is to help the skilled nursing facility control the patient's care while they're in the facility, and to reduce the overall cost to Medicare and the patient. So it is a coordination of care versus having people see multiple suppliers providing the care without the skilled nursing facility knowing. Therefore, the skilled nursing facility now can't establish their goals when a physician comes in to do the review. When a physician comes in to do their evaluations, they may not have all of that information. So the ultimate goal is to create that one oversight and coordination package. However, that does not mean that it doesn't have specific goals for the patient. Yes, is about better care, but it's also about saving the patient money. And if you think about that, if the skilled nursing facility has, remember those first 20 days where it's all free, but then 80 days of the 100 days, you have to pay a copay. You have to pay a dollar amount. So that dollar amount is assigned regardless. On top of that, once you reach those, you still have all the Part B stuff to meet. Well, what was happening is during that time, those 100 days, Medicare Part B was being billed as well. So we were assigning it to the Medicare Part B deductible, and then we were also assigning a 20% copay to services as well. So this patient was getting hit by both sections. The coinsurance, the 20%, and the copay from the skilled nursing facility, which was driving up their costs. Medicare said, hold on, we need to really reduce that. Also, Medicare was actually being billed and paying for duplicate services. So while a skilled nursing facility was doing certain things because they have and are required to do those, the patient was going to an outside provider and still getting the same service. And then they would bill both because they could. That's why it all came into play. So it's really about, one, controlling the care of the patient and making sure the patient gets the best care possible during the package service when they're inpatient in a skilled nursing facility. And then side effect, to control all those costs. So one of the biggest questions we did get was, who's affected by this? Don't know what happened, sorry. And it does have the potential to affect almost every type of provider. Now, I said the potential because a physician, as an example, your physician service, such as your evaluation and management service, may not be affected. That does not mean that a lab service that you perform may not be affected. It's two different types of services and paid under two different fee schedules. Because the physician fee schedule is not affected, but the lab fee schedule is affected. Okay, so then hospital imaging centers, yes, you could potentially be affected or not affected. Ambulance suppliers. This one is a very big, complex topic. We had a lot of questions come in on ambulance suppliers. I'm going to tell you that we're going to do a separate course for them because the topic is so complex. I can spend an entire hour just for them. Radiology centers are affected. Now, someone said, well, what's affected underneath there because there's a professional component? Right, that's not affected. That's a professional service, that's a physician service, that's a non-physician practitioner service. However, the running of the portion, the radiology, is affected, okay? Rehabilitation therapists, they're always affected. This is your PT, OT, and SLP. This is what the patient is in the facility for, therefore they are affected. Okay? And then again, physicians, as we described earlier, can be affected, although not all of their services are affected. And we're going to show you some files to look those up. I was also asked, are there type of providers that are just never affected? And the answer is yes, there are, but critical access hospital swing beds would be an example. They're never affected because of their payment methodology. Rural health clinics are not affected because of their payment methodology. Federally qualified healthcare centers have a different payment methodology. So because of the types of payment methodology, those three are not. Emergency room services billed with the correct revenue, all of that information are not affected. And we're going to look at that file because it's very specific. Again, most professional services, with the exclusion of PT, OT, and SLP services, regardless of how they're performed, are not affected. And then outside the scope of a practice or outside the scope of a SNF, this is lists done by procedure code on the CMS website that you'll have to use, and we'll look at those in just a few moments. So when we look at this, yes, there are certain categories of providers and services that are not affected, but then there's also a set of information that would fall into that. Okay. Reimbursement. When we look at reimbursement, remember, I talked about 100 days of the skilled nursing care is reimbursed. The 20 are full pay days and the 80 are co-pay days. Full pay means Medicare pays 100% of the allowed amount, while 80 says Medicare has copay assigned and that copay does get adjusted annually. This is Part A services. This is your inpatient, your room, your board, your nursing, your PT, your OT, all of that fits into that. There are other types of things that fall into that, which you do have to bill to the SNF, but the SNF would get an additional payment for, such as preventive care. This is a Part B service, but because the patient is inpatient, we have to bill it to the SNF. So there's a variety of different factors that play into that. Part B services can be included, and it just depends on the type of Part B service. We talked a little bit about that. So reimbursement is broken by Part A and Part B. The first thing you need to know with Part A, again, we're looking at Medicare covered services. If a stay does not meet the Medicare criteria for any reason, whether it's not medically necessary, then Part A stays do not apply. If it does not meet the 3-day qualifying stay, then it cannot be a Part A stay. Medicare is not paying for it. So there are some basic rules that need to make sure you go with that. If it is a medically necessary Medicare covered stay, you do get 100 days. That is the Part A stay, and that's all that applies to the Part A stay. However, clinical social work services also apply within the Part A stay. Incident to services. Now, incident to concepts, even in a physician's office, incident to services apply to the Part A stay. So while you could have a physician do it, the incident to does not. And then preventive and screening services. And again, some of those, the facility actually gets additional funds for. It's not part of their prospective payment, or it's not part of their per diem. So it's really going to look at some of those different items. Okay. There's also what we call Part B stays. Now, this means the patient remains in a skilled nursing facility and the care remains medically necessary. It's just that the 100 days are done, or they did not meet that first qualifying portion. In this case, all services with one exception are billed to Medicare. So they're in a Part B stay. Again, 100 days has lapsed. What's the exception for this one? During that Part B stay, PT, OT, and SLP services still must be billed to the SNF. The SNF is then responsible for billing Medicare. This is done because it's part of what the skilled nursing facility keeps them in the stay for under the medical necessity basis. Remember, it was skilled care such as this, or nursing care. Nursing care is not directly reimbursable, but PT, OT, and SLP are reimbursable under Part B. Therefore, the SNF must pay or must bill Medicare for them and all of the criteria that go with that. Okay, so that's a Part A and a Part B stay. One question that came up during the Part B stay: what happens if a service could be done by a PT, but a nurse practitioner did it? Now, I'm going to assume that you're talking about what we refer to as a sometimes therapy service. So when it's done under a plan of care, the PT could do it. But if it's not done under a therapy plan of care, then another provider can do it. It's just not billed with the particular modifier. However, under consolidated billing rules, these are not exclusions from consolidated billing, because the basic question stands with, why didn't the PT do it? And as long as they could have done it, it's still considered a therapy service. And I'll show you the files to look that up. Okay, so we wanted to make sure that we answered that question with this slide, and then we're going to move on. And I'm going to start again with the pre-submitted question. Then we're going to go ahead and do some, again, questions from the chat. And then we're actually going to go up to the CMS website and begin to look at those files, because there's a variety of things you do need to be aware of with the files. Okay, so first, let's clarify consolidated billing and its impact on professional services. First, define the professional service, because if you can't do that, then the impact, it's not something we can define for you. So let's start off, if it's a physician, what service is that physician performing? Are they doing something that would be a sometimes therapy service? That case, yes, it would impact that. Even that physician is not separately billable for that. Those therapy services are expected to be done by the PT, OT, or SLP, most cases it's PT or OT, when the patient is in that Part A or Part B skilled nursing stay. That's part of what the skilled nursing facility is being reimbursed for. That also means that if for any reason the patient comes in to see this physician and they do something or someone like that, it actually gets billed back to the SNF. Now, please note, I did not say the SNF knew or the physician knew at the time of service that this patient was in a skilled nursing facility. It's not part of the criteria that were under the law that enacted this. So hopefully all of that makes sense. At this point, Mary, do we have any questions?
We do not.
Okay. As I said with this section, I'm going to scroll through the slides really fast. I'll remind you guys to keep paying attention as I go through. I just want to get ready so that when I come back to the PowerPoint, we're at this question slide, because what we're going to do now is begin to come out to the website. The website we're going to start with is the CMS website. So this is going to be on your slide deck, and it's going to be it's literally labeled CMS website. That's the slide we're on. So the biggest piece you need to know about consolidated billing is that there is a website that is broken out by what is considered and what is not considered to fall under this bundling concept and when you need to build a SNF. The website is broken into separate files, so let's get to that portion. So first, we're talking about Medicare, so we're going to stick with that. We're not talking about Medicare Part C or Medicare Advantage plans. We're talking about traditional Medicare Part A and B. When we come down, we're going to go to coding and billing, and you can see it's the fourth item on the list. By doing that, you'll notice that on the right side, everything changed, and in the far right column, the second item is actually skilled nursing facility consolidated billing. That's where we want to go. Okay, so when we're on this page, there is some information that you'll want to read through. This just gives you a little bit about it. Someone asked me a specific question about what is the law or why does this even exist? It explains that this is actually part of the Balanced Budget Act. Congress mandated this payment methodology. They mandated this change. So then it was up to CMS to determine how to make it happen. So it is part of a federal law. Okay, I want to make that as clear as possible. This then amended the Social Security Act and the information within that. You can read through all of these different types of information. Kind of we went through a little bit about this. One of the things I do like is that if you're looking for some additional information, it will link you to the publications and also to the consolidated billing and transmittals areas down here. What I like about the consolidated billing area, before I leave this and go into these files, is that it does give you a lot of background information, explains a lot of different things. And we're not going to get into these today. Nobody really asked questions. So if you want to see these, you'll have to ask me. But it talks about all of those different things that I kind of went through. And on the very bottom, it gives you some best practices guidelines and some historical questions. So just nice pieces of information to have. I'm going to go back for a second. On the left side, there are two sets of files. There is the Part B MAC update file and the Part A MAC update file, Part A and B files, okay? One of the things I want to make you aware of is that these are updated annually, but in the in-between time, you may suddenly come out here and see a list of things that changed. And so there may be something that was added to the file, maybe needed to be added to the file, etc. And both the Part A and B files do have this. Okay, so you want to be aware of it. We're going to start with the Part A file, which is the lower one, the MAC Part A update. And we're going to see that we have major categories. Well, you don't really know what all of that means, right? I mean, okay, I can see that I've got a major category of something going on. So let's scroll down to the bottom. And you can see you have the file here, which will open in just a moment. And then you have the explanation of the file here, and that's the general explanation of the major categories. This is a key document, and you must be aware of this document. When I open this, it should open in a PDF format. It did. What it does is define for us the basics of using this file. Great, there's 5 major categories. This is when things should be submitted, etc. But then it goes on to define the major categories, and each major category has caveats. So it's not just as easy as, oh, yep, it's excluded or it's not. It's about reading the caveat and then figuring out which one goes with it. So here's an example. Major category 1, service beyond the scope of a SNF. Well, that sounds great. It's beyond the scope of a SNF. They shouldn't be able to do it. But then it goes on to explain that these services must be provided on an outpatient basis at a hospital. Well, that does include a critical access hospital only. not by a SNF. So that means that if this service was done at a freestanding diagnostic center, it is included versus excluded. Okay, so a lot of different things going on when you read through this, but you want to make sure that this is one of the key points. Again, reading down through, here's some information, and then you get to the general explanation of the major categories. And I want to point out just a couple. One, emergency services. If they don't bill it with the proper revenue code, and this does happen, these services are not excluded, and nor would a service related to it be excluded, which does sometimes hit us up. A related service for an emergency service could be the ambulance trip to the emergency room. So if the emergency room service is included, so would the ambulance service, because again, it doesn't fall under this revenue code. So there's an example of how to work that. Also, major category 1I, additional surgeries, exclusions. It talks about these services are additional surgeries, exclusions that do not apply within the outpatient, and they give ranges and all those different things. So you just want to make sure that you're aware of it. But I wanted to point out the additional surgeries versus the outpatient surgeries, because the outpatient surgeries list is an inclusion list. And we had questions come in. You need to tell me where that surgical procedure code is located so that you know if it's an inclusion or an exclusion. The one question asked, why is F suddenly this inclusion list? And the basic answer is there's just too many on the exclusion list that really a SNF can't do. So CMS felt like making an inclusion list for F was actually better than making an exclusion list. That's where it came from. If we go down, you can read all the other major categories, but just to stop here for a second, notice major categories must be associated for ambulance trips, must be associated with 1A through E and G, or 2A. Everything else is an inclusion. And then it just explains all the additional. Okay, so these are some additional services. These are ESRD patients or a hospice election, and then we can read through all of that. Major category 3, these are rendered by a certified provider, but not the SNF. So if rendered by the SNF, they're included. If rendered by some other provider, then they're excluded. Major category 4, preventive and screening. Now these ones do have to be billed by the SNF. So in terms of an external provider, they are billed by the SNF, but they're eligible for additional payments to the SNF. So we want to make sure we get that one billed correctly. And the last category is therapy services, which we talked about. And these are physical, occupational, and speech language. But as long as the SNF remains in a Part A stay, they must be billed to the SNF. And it's also for its Part A resident or Part B residents. So that's the basics of this one. What I'd like to do now is just take a moment and actually open the file up. The file looks like this. Oh, nope, sorry, I opened the physician file one. Not the correct file. We want this file. Now this file, you'll see it actually lists the major categories. You can pick any procedure code you want. So one of the procedure codes that I was asked a question on is 97597. Let's just go ahead. You can filter if you want, so you can put some filters up across the top. You could also use find. I'm just gonna do data filter. On this filter, I'm going to say I want to know about 97597. Go ahead and hit enter. It'll bring up the filter. So this is a debridement. Major category 5, which is an inclusion service. So this is considered major category 5. Remember, that was our PT/OT SLP services, and it is an inclusion service. So even if it's performed by someone other than a physical therapist, it would still be included. Okay. Now this is going to be similar to the other services, and we're going to jump back to the website and go back down for a second, because we also have the Part B services, which are this top one. And so we're going to look at the 2025. Now this one has 4 actual files. File 1, File 2, File 3, File 4. So instead of major categories, it has 4 files. Each file gives you, again, the updates. When you get to the bottom, sorry, there we go. You can read all about the different files. Now the difference is it'll tell you on the top of each file what you want to look for. This is the one that we want to look at right now because that's going to work with that 97597. So we're going to look at this part B. So it's file 4. So we want to go ahead and open that up. So it looks very similar, but yet different, right? Here's our procedure code. Here's our explanation. These therapy codes are subject to skilled nursing facility and must be billed through the SNF. Okay, so even if they're in a Part B stay, we know they have to be billed to the SNF if it's on this list. Let's do the same thing. Let's put some filters on. Oh, cool. And then let's go ahead and filter this list. Oh, because I didn't put the filters in the right row. Sorry, everybody. Let's put the filters on this row down here. Okay, that's not gonna let me put the filter on. There we go. And again, we're just gonna look for that same procedure code, that 97597. We know what's on the list, and what we find out is that, oh, even if they're in a Part B stay, this has to be billed back. So it's on both of those files, and the reason it is it talks about the Part A stay and the Part B stay. So hopefully that answers the question on the 97597. This is again a wound care procedure, and the wound care is considered a sometimes therapy service, but remember those sometimes therapy services are always part of the package. Okay. So I want to focus just for a second on show you the other files. So again, if we go back to the website, remember we had a physician service, we have a professional versus technical, and then ambulance day service. Now remember I showed you on the Part A one that there's an ambulance whole section on ambulance, and it talks about related to certain things. That's during a Part A stay. This will be during a Part B stay. So let's just start with file 1 as an example. So these are considered professional services, physician professional services, other than the interpretation of a diagnostic test. Okay, well, other than the interpretation is file 2. Doesn't matter. These codes are always billable to Medicare. So again, you can do the same thing. Look up any procedure code you want. They are physician services. Trying to think of anyone that I would just know off the top of my head. Not letting me do the filters again. So let's just say as an example, it's a 97213 or 99213. Let's do a 99213 instead. That's an office visit. We know what that professional service is. Well, I guess I can't type it. And so it'll say, hey, do you have a match? This case we do. What do we know about it? Well, we know it's an office visit and it's not included in this. That was just an example. So that's how we would use this file, but these are always professional services, okay? Then we also have file 2. Now remember, the difference between file 2 and file 1 is that these are the professional component. So these have to be submitted to Medicare, and it tells us right here, submit to Medicare with a 26. The technical component then gets submitted to the skilled nursing facility. And because of that, the skilled nursing facility may deny it if you don't submit with the technical component, just like Medicare may deny it if you don't submit with the 26. You have to use the proper modifier and bill the proper entity. And so then you can just go through and read all the different ones that would have a technical professional component. If somebody has something they would like me to look up on this file, please put that in the chat. I don't have a procedure code that anyone was really interested in from the questions that were pre-submitted. So I will put that out there and let you guys put that in the chat should you have something for me. All right, the last file that we actually have is the ambulance file. Now the ambulance file is talking about billable codes for ambulance. And the key thing that we have to know about billable codes for ambulance is they are only billable if they do not apply under the bundling process. So remember when we talked about the services in major category 1, and then the services in major category 2A, and they're separately billable? That's when Medicare will pay these codes. Otherwise, the ambulance code will bundle if it's in one of the other major categories. And those codes are not payable, nor is the ambulance revenue code it's actually considered part of whatever the procedure happens to be. That's why we do have to talk about ambulance as its own course, because it gets to be a lot when you have to look back and forth. Okay, there's a lot of information that goes into it. So those are the major categories where to locate the information and things you might want to know. Okay, I do always recommend taking a look at it. I always recommend going back to that main page, scrolling down and taking, again, a look at the publications, but especially this consolidated billing page, just again to highlight a few things on here. Please scroll down, read the information under the Government Accountability Office, the OIG reports. It is some stuff that is still being looked at. If you are interested in the laws and the sections of the laws and all of that stuff that created this, it is all here for you. Now, the reason that I bring this type of information up is that there was not quite a few, there was actually like 2 or 3 questions about that. And so that's why I thought, well, let's just bring it up and show it to you this way. Okay. So here's another law that you might want to take a look at. And I'm not going to get into all these different sections and how the law has changed over the years and the things that have happened. We're just not going to do that. Here's the basic section for 1888, and it talks about the Social Security Act, and then it specifies certain things. So there is a lot of information just on these 2 pages, the consolidated billing page and then this one, that you'll need to be aware of. Okay. Just lots of stuff for you. All right. Let's leave this page for a second here, and we're going to look at WPS website just for a brief moment. So we do offer quite a few different things on consolidated billing, and I will tell you that ours is based in a line of business. So when we say Part A up here, it's those billers on a UB04 or 837I electronic transaction. That's the line of business for CMS. The line of business for Part B is only those on the CMS 1500 claim form or 837P electronic transaction. So remember, we talked about Part A and B services and how they're different. It's the same thing on our website. We use line of business. That's why you want to make sure you're in the correct area. Most of the consolidated billing information will be available to you in the claims section. And you can go through, and if you actually come down, you'll see consolidated billing. And just a couple of things to help you understand. Here's one major article. If you go down a little bit further, you'll see all the different sections. A lot of people will actually type. I don't recommend typing the word Medicare. Don't start with the word Medicare. If you're going to search, avoid that on our website and CMS's website. It makes sense if you start with something different. I like the term consolidated as I'm searching. Okay, and there you can see it. Here's the one that we just looked at. My denial due to SNF Consolidated Billing. This is an FAQ. So I like that word, again, consolidated. And I think that it works the best because it's the most unique when it comes to the terminology. You know, you don't want to search everything and then get a bunch of different stuff and you're like, oh no, I got to search through all of these different hits and which one applies to me. Try not to do that. Okay. But let's take a look at this one, and this is an MSP fact sheet. So if you want to know more about consolidated billing and Medicare secondary payer, which by the way still applies, it'll help you understand that. But I do want to point out here, you're telling me that the line of business, this is for the Part B line of business. However, you are in the Part A section, and that happens from time to time when you go from the search feature. Same thing if I went into this one and then I went into a Part B line of business, it tells me this isn't for you. Now remember, line of business on our website equates to how you bill. A UB04 or an 837I, you are a Part A line of business. A 1500 or an 837P, you are a Part B line of business. What's great is you do happen to be inside this Part B one and you're just looking for basically just a really fast update. I'm sorry, the Part A one, and you're looking for just a fast update. This will kind of walk you through the major categories, kind of go through all the different information, help you kind of determine without having to go out and use all of that. But keep in mind, the procedure codes are key to this. The revenue codes can be key to this. We saw that, right? If it's not billed with the proper emergency room revenue code, that does affect the service. So you want to make sure you keep all of those basic caveats in mind while reading this general stuff. Let's jump back here. We have something similar, and it's called a quick reference. There's two different ones. There's one that I want to point out here. This is again going to tell us, hey, I need to be in the Part B section because that's the line of business. So let's just flip to the J5. And then this is just a very, very fast quick reference. It is not designed to be the end all be all or all encompassing piece of information. Okay? I do get questioned on this one on occasion, and that really is about the modifiers that are billed with it. Right here, I'm sorry, the second one up. Okay? The modifiers that are built with it. So there's a lot of stuff going on there. Again, we do have one specific just for ambulance if you wanted to look at that. I keep coming back to that because I did, again, have quite a few questions. There we go. It's the ambulance quick reference. And this one will just help you through some of the ambulance situations that you might want to know. Okay. So both websites do contain a variety of pieces of information. I'm going to go through I'm going to actually ask Mary if we have any questions at this time, and then if we don't, we'll get started on the pre-submitteds, and we'll come back to those. So Mary, do we have any questions?
We do not.
Okay. Well, I'm just going to roll through the pre-submitteds, and then again, if we have time, we'll come back. Can you clarify which services and providers are excluded from skilled nursing facilitated billing and how we should bill these separately to Medicare? So again, go back to that list. It's really about one, the service that's being done, the procedure code. Two, is it done in a certain place of service, such as a hospital or critical access hospital, and dependent upon? And is it a professional service? So go back to that list, determine it from there. In terms of how you bill Medicare for separately, you're going to follow the same billing rules that Medicare has for anything else. It doesn't change. Okay? It doesn't change at all. Next question is, what should we reimburse someone at? I'm going to assume that you mean what should the SNF reimbursement be from the SNF to the outside provider, or from, what should the outside provider expect from the SNF? And the answer is Medicare does not determine this reimbursement rate. It's not something that we're involved in. This is a legal question between the two of you. So if you have a contract, follow that contract. If you don't have a contract, as an outside provider, you can expect up to the full billed amount, but you get to choose what you want to take. If you don't agree with it and the SNF isn't reimbursing you at whatever level, then it's a legal action to be taken because it's a debt owed. Next question, what common things are not covered or included in consolidated billing? First, the most common one is ambulance transports to the skilled nursing facility or to an ER service, but the ER service must be billed correctly. We saw that earlier. Also, outpatient hospital services falling under that information in major category 1 are actually very common for the exclusion list. And then the other one is literally excluded services, like things that are never paid for by Medicare. If they're not paid for by Medicare, don't bill the SNF. The SNF should send it back to you saying, not our bill, not our responsibility. Is there a third-party company that you can recommend that would help with this subject and would know the rates and stuff like that? And the answer is no. WPS cannot recommend anything. Medicare is not involved in that process. If they're out there, they're for you to discover and to find. We cannot be involved in that. Next, why are the bills split? Some charges to Medicare and some to the skilled nursing facility. As I showed you on the CMS website, this was part of a federal law, which was then incorporated into the Social Security Act and adjusted that. So go back and read the Balanced Budget Act of 1997. That's where it came from. This was a Congress mandated payment methodology to, one, to get the SNF better control over the care provided to their patients, but also to save Medicare and the patient money. Next question, why aren't the SNFs listed in the WPS? I'm going to assume you're talking about our Secure Net Access portal or our website secure section, whatever you want to call it. And the answer to that is there's a transaction that we use, which is called the 270-271 HIPAA eligibility transaction. That's the big name for it. This is a CMS required transaction, and that transaction does not contain that information. Therefore, we can't provide you anything other than the information in that transaction. I know a big long explanation to basically say we're stuck without it just like you guys are. Okay. Is a transition care unit part of what would be consolidated billing. And the actual question is TCU, and I'm going to assume you're talking transition care unit. Let me state it that way. I'm going to assume from the question, is TCU a part of consolidated billing? I'm going to assume you're talking transition care unit. And if that is what you're talking about, the answer is yes. Can you tell me what services they're providing? Yes. Can you tell me what services they're providing? Because they follow the same rules as everyone else. Next, how to pick the proper diagnosis if the hospital is not giving the specific diagnosis. Step one, go back to the hospital and see if you can get it from them, get something from them. Step two, do whatever you need to do based on the information and the documentation that you have. We cannot help you pick a proper diagnosis because we don't have a medical record to view. We don't have anything to help you with that. So there's no way for us to help you with that. And CMS does prohibit us from giving coding advice, and that would be considered coding advice. So first, the next question says we do not perform blood transfusions in our skilled nursing home. We do send them to a Part A resident to a local hospital. Our nursing home gets the bill for this and we pay it under consolidated billing. It's very expensive. Yes, that's true. That is what's supposed to happen. No, you're not missing anything. No, if you don't have an established contract, yes, you may have to pay up to that billed amount. There's nothing to stop them from asking for that. When Medicare reimburses you for this, they don't necessarily reimburse you directly. What they can do is have you add it or do a corrected bill, which again could happen a month later, 2 months later. It just depends on when that gets billed to you. So we do know that that does happen too. You can file certain things on your cost reports. So there's a variety of different ways, but it does not necessarily increase your prospective payment or your daily payment rate that you got for this service. Okay. I also had a question, and this is a Part B billing question, which Part B being a 1500 or 837P, and they're talking about the correct billing of place of service. Now, my assumption is that you're talking about place of service 31 and 32. 31 is used when the SNF is responsible for paying a portion of the service. In other words, the Part A stay when consolidated billing applies. 32 is used when the SNF is not responsible. Hopefully that answers your question. And so there's a lot of, there was a couple other, again, questions on ambulance. We went into them. I do recommend that you register for the 8-12 class. I know that we're pretty much running out of time, but I just want to make sure that we didn't have any more questions submitted in the chat. Mary, did we have anything?
There is no questions.
All right, well, let's finish up then. So I want to tell you all that we are changing our customer service process. This involves when you do call us, the process says that you get one PTAN MPI combination per call. If you'd like to learn more, I do recommend that you take a look at our website article. Mary put that link in the chat for you, but also please remember this is effective on August 4th. You will receive an email directly following. The email will contain your certificate of achievement on the bottom of it. So don't just delete the email. Wait, read it. The certificate has contact hours. Governing bodies decide if those contact hours qualify for continuing education units. We do not provide continuing education units. It's up to a governing body. Okay? You will see that you will have the opportunity to take the survey within that, but also you'll be given another opportunity to take the survey. We'll talk about that in just a few moments. If you have additional questions that come up in the next 7 days, I'd love to hear from you. Please email us those questions, making sure that SNF Consolidated Billing Basics is in the subject line. Please take our survey. I'm going to have Mary put a link to the survey in the chat. I also told you that I'm going to give you a link to the survey in that follow-up email. Also, because we're not done yet, we want you to take the survey so bad that when we close this webinar, we will give you a link, and that's going to be in the bottom picture, which is the external site. You'll see a little triangle. That's going to have the survey link in it. This is not spam. This is not malware. This is nothing like that. This is just something we could do. Okay. So let's try to be the one that does the best and get all those surveys returned. I want your survey so bad that if you are taking this as an encore, we'll ask you to do it again. What do we do with the surveys? Well, we actually do listen. A couple of people have asked us about this, and we do listen. So one, we have done training indicators. Those are our newest things, and they're out there in the e-news and on our WebEx ads. We've done chapters in YouTube. We're currently looking at how we can fix, change, adjust, whatever you want to call it, our training center, on our website. So we hear you, we understand, and we want that feedback. We need that feedback. Otherwise, we can't make those changes. All right. So thanks for listening. Thanks for giving me those couple extra minutes just to run through all that stuff. We do want to encourage you to provide feedback on the survey. Remember, the feedback is good, bad, whatever you want to give us. Tell me what I did well. Tell me what I could have done better. Tell me if the websites were helpful, not helpful, whatever you want to need, whatever you want and need. Also, if you have topics not related to skilled nursing consolidated billing, please include those. If you have topics related to it, include those. Continue to watch our website and advertisements, as we will have more classes for consolidated billing. We do understand this is a big topic and there's a lot more that goes into it. I will recommend that you continue to watch our live events page for additional registrations, again, on consolidated billing and other things. But on behalf of myself and Mary, we want to thank you for your participation. We look forward to your survey comments, and we hope that you'll join us again in the future. You may now disconnect.